Hello, my name is Peyton Cuellar, and I'm going to be presenting about dental attendance in Latino children. The population that I am focusing on is Latino children between the ages of 0 and 18. Important information to note is that only 34.7% of children had a regular dental office visit or received any sort of dental care between the years of 2010 and 2012. And 27% of Hispanic children aged 6 to 11 had a cavity between 2011 and 2012, and 9% of Hispanic children had untreated decay between those same years. This is important because untreated tooth decay can lead to a multitude of problems, including pain and infection, problems with eating, speaking, and learning, as well as it is a proven fact that children with poor oral health have more times that they have missed school and received lower grades than children with good oral health. It is also proven that absences that are caused by pain were associated with poorer school performances, but absences that were for routine care, such as cleanings and other dental exams, were not affected by this at all and had regular performances at school. There are a multitude of different factors that influence dental attendance in the United States. Harris and Whitehead found that a person's perception of their oral health, including if it is a poor perception of oral health, they are less likely to visit the dentist the poorer it is. This is due to shame and fear that they may feel that they will be judged for having poor oral health, as the United States has placed a high value on perfect, straight, white, clean teeth. It was also noted that dental care is viewed by society as less necessary than other medical procedures, and this is in part due to that cosmetic feel or aesthetic feel that dental care receives and the way that it is treated separately by insurance. It was also noted that there is a low health literacy level in the United States, especially in regards to dental. Lower income, of course, or lower social economic status does affect dental attendance as well, not only in regards to the expenses that are related to regular dental care, but also the inability to reorder schedules to be able to attend dental visits. Typical dental offices are only open between the hours of 8 and 5, which are also standard working hours. If you are struggling to make ends meet or living paycheck to paycheck, sometimes taking that time off for you to go to the dentist or for the child to go to the dentist isn't that something that is available, which makes it difficult. It was also noted that even if you were lower income and close to a low income or a public health-based dental office, it does not necessarily mean that you will have a higher likelihood that you will be going to the dentist. It was also noted that parents that were happy with their oral care were more likely to take their child to the dentist than the ones that were not. It was also noted in Lee et al., which was a study that was done in Taiwan on reasons why parents were not taking their child to the dentist, that perceived susceptibility and perceived barriers were the main factors that caused the children to not be going to the dentist. Even though the children had positive views of the dentist, parents typically noted if they lived in a rural location, the perceived lack of access to services, as well as the distance that it would take to get to access these healthcare services. Cultural factors to consider when working with the Latino population can be seen in Hilton et al.'s interview of 177 immigrant, primarily Latino, Chinese, and Filipino parents that were interviewed, that the parents lacked the knowledge of the importance of primary teeth, including the importance of the primary teeth to be able to guide the adult teeth into proper placement, and they were seen as replaceable teeth, so any cavities that may have formed on them didn't matter, though it is possible for a cavity that is in a primary tooth or a baby tooth to be able to travel deep into the tooth and then up and affect and cause cavities on unerupted adult teeth. This was also noted in Hoft et al. From 2010, where they interviewed 48 Mexican-American mothers in both English and Spanish on their perceptions of oral health, their child's oral health habits, as well as their child's caries risk factors. It was noted that the mothers mentioned that candy, juice, poor oral hygiene, and prolonged bottle usage is what caused cavities. And authors noted that there was a severe lack of knowledge in the fact that bacteria is what was causing the cavities, as well as the knowledge of what other cariogenic or cavity-causing foods that their child was being exposed to. This can be seen in a mother not understanding that getting her child off of eating candy, juice, and soda was great, but she had replaced it with ice cream bars and Gatorade, which all have very high sugar contents as well as acidity levels for the most part, and does not actually reduce her child's caries risk whatsoever. It was also seen that the belief that visits to the dentist were unnecessary due to regular visits to the pediatrician. They believed that the pediatricians were adequately equipped to be able to assess their child's oral health, and that they would know if there was a problem and would let them know beforehand if there was a dental problem, as well as give them the necessary tools to fix that, including suggestions to dentists to go visit. Another thing to consider would be that the entire family unit is included in the decision-making process for health care decisions, including people like aunts and uncles or grandparents, and sometimes even cousins. The final thing that would affect their ability to go to the take their child to the dentist would be their own personal fears of the dentist as well, whether it be due to pain that they had experienced and not wanting their child to experience that same pain, or having experienced culturally incompetent care from previous healthcare providers and feeling like they are being over or under treated. Interventions typically fell into two different categories: text or phone-based interventions, as well as educational interventions. Starting with the text or phone-based ones, we are starting with Lozoya et al., which was a smartphone app that was used to help engage the children in toothbrushing behaviors, educate parents on oral health habits, and give them reminders to brush their child's teeth. This intervention was found to have very limited effects on perceived behavior control because it was focused on theory of planned behavior, though the parents did find the phone app to be helpful for them. Schulter et al. Was a motivational text messaging program that was used to increase teeth brushing behaviors in teens and unemployed 18 to 24-year-olds in rural New Zealand. It was found that motivational text messaging that included information on susceptibility, severity, and beliefs were able to influence the behavior of teeth brushing. Borelli et al. Created a program that sent text messages to low-income parents to remind parents of proper oral home care, including dental visit reminders and assistance in finding a dentist. It was found after applying social cognitive theory to the results of their intervention that text messaging was an effective way to influence knowledge and change the behavior of parents in regards to their child's oral health. In regards to the educational interventions, Solatani et al. Focused on a group of Iranian mothers and had them go to 3 different educational sessions to increase the amount of oral care that they were participating in with their child. The study found that not only did this educational intervention help improve the oral health of the children, it also improved the mother's oral habit health as well. The study also found that the perceived behavior control score did go up in a positive way. Ghaffari et al. Also focused on a group of Iranian mothers, but it focused on expecting mothers and educated them on the risks that poor oral health can cause during pregnancy, including increased cavity and periodontal risk, as well as other adverse pregnancy outcomes like preeclampsia, preterm delivery, and low birth weight babies. This increased the perceived severity and benefits to oral care, and authors did also mention that a lack of knowledge was a possible reason why there was a lack of engagement in dental services within these populations. Hoft et al. From 2016 created a program using social cognitive theory to help educate Mexican American caregivers of the children ages 0 to 5 on oral health. The researchers found that after creating this program with a specific step of social cognitive theory in mind, that there was a significant change in knowledge after the intervention and a positive change in behavior due to this as well. When thinking about these interventions and what to do for my own interventions that I'd be creating, I decided that I would be using the belief model. Sine et al. Proves, which is a meta-analysis of all theory-based interventions for oral health interventions, that theory of planned behavior and the health belief models were the only models that were effective in making lasting changes in oral health behaviors. Authors did mention that social cognitive theory could potentially be helpful, but all the research on social cognitive theory, the researchers applied it improperly, which led to mixed results. They also mentioned that the health belief model was effective on both adults and children, whereas all other results showed that it was primarily effective on changing the behavior of children, which is important when looking at dental attendance, because you not only need to change the parents' behavior to encourage them to get their child to go to the dentist, but you also need to work on getting the child being willing to go, as proven in Weinstein et al., where parents were alerted to the needs for the dental treatment of their child and offered free dental care. And if the child was not willing to go, the child still did not attend at dental visits. My theoretical intervention would be very similar to the Boreali et al. Intervention, would be a health belief model based text and or phone reminder system and educational intervention. The educational intervention would include presentations on the importance of oral health and focus on caries and how to prevent them, importance of dental visits, as well as information on local dentists, that and including fee schedules that they would accept, as well as what other insurances they would be taking as well. The phone and text-based reminders to schedule appointments would include information on local dentists as well as other healthy oral habits to be considered while at home. Some cultural and ethical considerations to consider while utilizing my own intervention would be that the family unit isn't fully considered in its entirety in this intervention. It doesn't include any influencing factors of grandparents or uncles or aunts. It does primarily focus on the child as well as the primary caregiver. The other thing that needs to be considered is that they may or may not have phones that receive text messages or have access consistently to one phone. It is frequent that they will write down friends and family's phone numbers as their own and will utilize one shared phone line. No ethical concerns are found with this intervention because it is a voluntary-based intervention that causes just reminders. No HIPAA violations would be created because there's no actual health information being passed between the phone and the person. It would just be reminding them to go to the dentist. Now, if you have any questions for me about my intervention as well as cavities or dental at all, please feel free to leave any comments down in the questions below and I will be happy to answer them. Thank you so much for listening.